And following this talk, I would like to invite our next speaker, who will be talking on the clinical, psychological, and neuropsychological trajectories and facial morphology in CTNNB1 syndrome. Dr. Neus Martinez Abadías. The floor is yours.
Okay, thank you so much. Thank you very much, and good afternoon. I wanted to thank the organizers for providing us the opportunity to participate and present our work in this meeting. But also, I wanted to acknowledge that most of the work was not done by myself, but my colleagues, Mercè Pallares Sastre and Aroa Casado, which couldn't attend today the meeting, and that's the reason why I'm presenting on behalf of them and on behalf of our collaborations and colleagues at Universitat de Deusto, Universitat de Barcelona, and other Catalan and Basque Country institutions, research institutions. Okay, I think we all agree that we know what is the main cause and the main core manifestations of CTNNB1 disorder, and that there are many genetic mutations that alter the CTNNB1 gene, that it's altering beta-catenin, and that is leading to a heterogenic phenotypic profile with all these characteristics. But I think we all agree that there are many gaps that we needs that we keep continuing our research, and my colleagues previously have already been talking a lot about the trajectories, the life histories. We need to learn more how these traits are changing during the lifespan of the people that have been diagnosed with this disorder. And I am particularly interested in the craniofacial phenotype. Amaya has already highlighted that there are facial traits that have been associated, described in this disorder, but we still are lacking a quantitative, precise method to quantify this facial pattern and to use it for maybe with some potential diagnostic or prognostic potential. And we are also interested between the link. What is the association with these cognitive, behavioral, motor traits and the craniofacial phenotype? Is there something that is underlying them that could, if we understand this association, could help us contribute to improve the prognosis of the patients with this disorder? So our hypothesis is that we have to think about the role of beta-catenin. We all know that this is a protein that is regulating and has a main role in regulating neural crest induction. And these cells, the neural crest, are the ones that early in development are going to give rise to both the brain and the face. And they are also important in the development of the central nervous system. And that's our hypothesis, that if there is a haploinsufficiency in CTNNB1, maybe that is leading to some alterations in these circuit levels that are changing things, and that for us is the explanation why there could be shared biological substrate for facial and neurodevelopmental phenotypes in this neurodevelopmental disorder. So, my colleagues at Universitat de Deusto, they organized this longitudinal study in order to give answers to the first question about trajectories, and they recruited small in comparison to the larger Dragonfly longitudinal analysis, but still very large sample of Spanish individuals diagnosed with CTNNB1. It included 25 people, 16 girls and 9 boys between 3 and 18 years old. And they organized this longitudinal study. They did a battery of neuropsychological, clinical, and psychological questionnaires at 2 time points. They separated by 1 year, and these were in-person and parent-reported questionnaires. And also they organized so that the participants, they also underwent cross-motor functioning that was applied by a physiotherapist. I will briefly go through the results because this is not my expertise, but mainly what we would summarize is that when they were considering and analyzing the differences between the time baseline and 1 year after, there were no significant changes in most of the cognitive measures that they assessed, except one. And then regarding the behavioral trajectories, when they were analyzing the results from the Vineland battery, also they didn't find, let's see here, that this p-value, they didn't find significant differences between the two time points. Even if we here in the graph, we see this, every line represents one of the patients, and we see this downward trajectory that could be interpreted as a worsening, but actually Mercé and Maitane, they think that this is more a representation of a floor effect, because this instrument is not adjusted for people with disabilities. But the important thing here is that they didn't see significant changes when the overall score of the Vineland instrument was assessed, but this instrument can be separated into 5 different domains: communication, daily living, social skills, socialization, internalizing problems, and externalizing problems. And by looking at the results more specifically by domains, they did find some improvements after 1 year in communication characteristics and daily living skills. But again, overall, the main result would be overall stability over 1 year with some specific improvements. Then they did detect some improvements and significant differences when they assessed motor trajectories. And they were identifying the significant improvement after 1 year in the battery that was assessing motor functioning. And they could be related to the physiotherapy that most of the children were undergoing, because they found that that was one of the therapies that the families were investing the most. And well, here's the result, the positive effect, and underscoring how these therapies are really helping the children. Then, to answer the second question, whether we could quantify more precisely the craniofacial phenotype, what we did is to collect 3D facial images of all these children, and I'll show you in a moment how we do that. And then we also collected a control sample that was matched by age and sex for the individuals for performing comparative analysis. And here's the system that we use is a photogrammetric system that it's made by 10 cameras that they are controlled remotely. They are all shot in the same moment, so you have 10 pictures of the same of the person at the same moment. And from there, in a software, we can reconstruct the 3D facial morphology. And from there, what we do is to register the 3D landmark coordinates of a set of 21 points. And from there, we do statistics. So these are the points that we collect to represent the face. And here you can clearly see that the result of the statistical analysis is that we can clearly define a facial pattern characterizing CTNNB1 patients. Here they are clearly separated along this axis. And here we identify so that in children with this disorder, they show narrower faces, a slight mid-face projection, flattened nasal bridge, reduced infraorbital convexity, thin upper lip, and chin retraction. And that these methods, that they are called geometric morphometrics, can be useful tools to do a step further in this description of the facial phenotype. And then what we did is to search the link with the previous cognitive neuropsychological measurements, is that we looked for associations between this facial pattern and the variables assessed by our colleagues at Deusto. And for all of them, we had many of the measurements. We only found a significant association with externalizing problems and the critical problems. And what was interesting there there was to find that children with higher scoring of this type of problems, they were showing a more severe facial phenotype, like the characteristics that define that are associated with CTNNB1 syndrome were like more pronounced in cases that were having higher scorings of these problems. So this opens the door for future avenues of research to see if this can help for the prognosis. There are many limitations in our study, starting from the small sample size, but we have plenty of ideas how this can be overcome and how we can continue with this research. So with much further, I just wanted to thank you for your attention, and later I can be happy to reply any questions.